So one of the questions we get a lot is about airway. And airway is one of those terms that's been thrown around a lot more recently than in the past, and there's a lot of good reasons for that. There is so much science and research behind breathing properly and sleeping properly, especially in kids. And this case demonstrates that pretty well. So let's look at this together. So this child came into our office, and when you first look at this case, you might go to 10 different orthodontists and get 10 different opinions about what you should do or shouldn't do with this case. And 10 years ago or so, when I was in residency, if I would have had this case presented to me, I would have made a very convincing argument that no orthodontics needs to be done on this child until they're older. And you still might have practitioners out there who make that same argument today. I'm not one of them, and I'm going to explain how my thinking has shifted. I want to go through with you what we try to accomplish in these cases. And so this child, there's some signs that stand out to me. So one, he has what they call scleral show, which basically means that when his face is relaxed and his lips are relaxed, you see the white underneath his eyes. Now, this is something that if you have no idea what that is, it wouldn't stand out to you in any way. Some people have it, some people don't. But that's one sign that possibly the growth pattern is not quote unquote normal. Another thing that stands out to me is that when I look at the jaws of this child, they look to be growing in a downward, backward growth pattern. We're going to go through some of the other imaging so that may be more clear going forward as far as what we're looking at. Now, from a dental standpoint, you probably haven't counted the teeth, but there's actually not room for an entire tooth on that bottom left side. So you can see that when that permanent tooth came in on that left side, 2 baby teeth were removed during that process instead of 1. And so there's not a lot of room for those teeth. This image again shows that scleral show underneath the eyes. And when we look here, this is the smile that he gave us when he first came in for his exam. Looking at the teeth on the top, you can see that the top 2 teeth are missing. And when we look at the bottom, you can see on the bottom left there needs to be a permanent tooth in that small space, and there's no room for it. A lot of times what happens is when you have a jaw that is undersized, like the top jaw for instance, the lower teeth, they compensate, which means that the lower teeth tip inward and the upper teeth tip outward to try and meet together. So Mother Nature is really good at camouflaging things, but when I see lower teeth that are tipped in and not enough space for the teeth, one of the first places we evaluate is the top jaw to see if it's wide enough to be coordinated with the lower jaw and also to make room for those teeth. This is what that looks like on the x-ray. So you can see underneath the baby teeth are all of these permanent teeth. And these permanent teeth need room. You can see that there's a lot of room for some of the permanent teeth. His front 2 teeth, for instance, they should come in no problem. But when it comes time for those canines to come in, that's when we run into trouble because all of the rest of the teeth, the permanent teeth, come in and take up the space, and then there's not enough room left for the canines to come in. And that's why the canines become impacted more than almost any other tooth. One of the things we look for at this age is we want to make sure that the child has enough room for their teeth to come in. If they don't have enough room, there's a few things that are not ideal that could happen. So one of those things, one of the most common things, is what we call impaction, meaning that the tooth will not come in at all. So it's most common with the canines because they're one of the last teeth to come into the mouth. And what happens is in a crowded case, all the rest of the permanent teeth come in, and then the canine is left without any space to do so. And so if they become impacted, it might be to the outside, it might be to the inside, but either way, what has to happen is you have to go to the surgeon. They have to expose, meaning remove all the bone and gums on top of the tooth, and then we have to make space orthodontically with braces or aligners to bring that tooth into place, and then once it's in place, we can straighten it and get the bite as good as we can. It's not that that's impossible to do. We do it all the time, but it does create a situation where at the end, we might not have as ideal of a result because things can happen in surgery. For instance, you can have complications. The tooth can come in an area where the gums are not as strong, so they may be more prone to recession. The tooth can look longer or shorter. The tooth can be damaged during surgery. So it's much easier to prevent those problems from happening than to try and deal with them after they have happened. And ultimately, if the reason that the tooth is crowded is because the jaw size is too small, then even if we try to make space with braces and bring it down in, if we don't address that jaw size, it's never going to change. It's going to stay small, and you're still going to have those complications later on in life, which we can talk about. The second thing is we want to avoid having to have permanent teeth extracted. One way to deal with teeth that are impacted or not coming in or crowding is to extract permanent teeth. This is something in our profession that we used to do all the time. Anybody, my parents' age or older, if they had braces, almost surely they had 4 teeth extracted, or many of them, a lot higher percentage, had 4 teeth extracted, because back when orthodontics was younger as a profession, we didn't really have the imaging that we have now. We didn't have all of the tools at our disposal that we have now. And so we made the best decisions that we could based on the information that we had. And what we could see in the mouth is that there was not room for teeth. And so one of the ways to make room for teeth is to pull permanent teeth. And when there's less permanent teeth, there's more room for the ones that you have. But again, that doesn't address the underlying jaw size discrepancy if that's present. So basically, it's a Band-Aid. And at some point in your life, you're likely to experience the complications of not resolving the underlying issues. Namely, a lot of patients deal with possible airway issues down the road, meaning sleep apnea, breathing problems, sleeping problems. Because when you extract teeth, one of the things that happens is that all the other teeth constrict. Almost never do you need the amount of space that you get with extracting 4 permanent teeth. A normal tooth is about 8 millimeters in width. So that's about 24 millimeters of space that you free up when you extract teeth. But not all that is used to align the other teeth. Some of that has to be closed by constricting the arch form, making it smaller. So one, you end up with an arch form that is not necessarily as aesthetically pleasing, because most people don't love the look of a more narrow arch. But two, you have less room in your mouth for your tongue and everything else that you'll need in order to be able to breathe as ideally as possible and sleep as ideally as possible later. So we try to avoid pulling teeth, especially when the root cause of crowding is a jaw size discrepancy. The other thing we try to avoid is what we call root resorption. So permanent teeth are designed to dissolve the roots of baby teeth. A lot of people, when they pull out their baby teeth, they just think that those teeth never have roots, but that's not the case. You can see on this x-ray the baby teeth have roots. But what happens is, as the permanent teeth erupt down into place, they dissolve the roots of those baby teeth. Well, when there's a crowding situation, what can happen is these permanent teeth, they don't always know which ones are the baby teeth and which ones are other permanent teeth. So they can get confused and they can start to dissolve the roots of the lateral incisor. And now when that canine comes in, instead of a baby tooth becoming loose and coming out, the permanent tooth becomes loose and comes out. Thankfully, this is not an extremely common complication. So the incidence of this is pretty low. But if that happens to you, now you're in a situation where you have the wrong teeth in the wrong places and you have the wrong number of permanent teeth. Most likely you're going to be set up to have an implant later on or have to extract additional permanent teeth to try to make it even or balanced. And it's a not ideal situation. It's not easy to deal with. So if we can make room for the teeth and minimize the chances of that happening, that's what we're going to do. The last thing that we try to avoid with crowded cases is when teeth are crowded, there's 2 things that are more difficult to have happen. So one, oral hygiene, brushing, flossing is a lot more difficult when the teeth are crooked. But 2, when the teeth aren't fitting together properly because they're crooked, you might have a tooth that's hitting right on the edge of another tooth, and that bite relationship is not normal. So what can happen, even from the age of 7 to, let's say, 12 or 13, when most people get braces, you could have severe wear on your teeth. And this is something that if you are not aware that that can happen, can easily be missed. I've had hygienists' kids come into my office with severe wear on the lower front teeth, and nobody noticed, because what happens is when the teeth wear down, if they're just a little bit crooked, they actually start to look straighter because the edges are worn down flat across. And so when that happens, it's very difficult to detect. And, combine that with not always getting into the dentist on time or maybe missing some appointments. And it's a recipe for disaster, because by the time you do come in and you're 12 or 13 years old, we can straighten the teeth, but then we're the bearer of bad news because we have to tell you that, really these teeth are like this and they look flat, but when we straighten them, you're going to see the edges and how worn they are, and you'll have to look at getting those restored or do some other procedure. So if we can prevent that from happening, so much easier to fix it after it does happen. So getting back to this case, the downward-backward growth pattern that we see, when you look at this image, it becomes the most clear. When you look at the face and you see that top jaw, if you measured this out, is set back relative to the rest of the face. The lower jaw is even more set back. Another thing that we notice is what we call the chin-throat length. So the further back the lower jaw is set back, the shorter the chin becomes. everything attached to that lower jaw determines your long-term airway health. And so you have your tongue, you have your pharynx, you have your tonsillar pillars. Everything that's attached to that is going to be moving backward if your jaw growth is downward and backward. This is something that in recent years they've done a lot better job of educating about, but still there are so many people that have no idea what affects this growth. So one of the things that affects growth in every kid is genetics. Now obviously at this point of our scientific development and careers, we don't really have a great way to alter those genetics in a favorable way. So there is going to be a genetic predisposition to how kids grow, but there is also what we call an environmental component, meaning that when a child grows, that the physical things that are happening around them have an influence in how they grow. And this has been well documented in identical twin studies. So you have one grow up this way, one grow up that way, and you see the difference in their growth patterns. So both are important, but we only have control right now over one of them, and that's the environment. So when I see a downward, backward growth pattern like this, one of the things that comes to mind is like, is this child mouth breathing? And you know, you may have heard about mouth breathing or know a little bit about it, but basically kids grow at night. That's why it is so important for kids to get good sleep, because if they're not sleeping well, they're not growing well. You have some physicians who recommend before a child goes on growth hormone that they actually get a sleep study first. And the reason for that is that if a child has sleep disorder breathing, maybe some form of apnea or even something less severe, RERAs that aren't technically apneas, but they are affecting their sleep, if those things are happening, the growth hormone is going to be diminished or shut off. So basically, if you're not sleeping well, your body is going to divert its resources to get you to sleep well, to actually keep you alive at night. And the growth takes a back seat. So normally using those resources to exert that growth hormone and have a child thrive from a growth standpoint, that's normally pretty important, but it takes a back seat to surviving and not choking at night because you're having sleep problems. And so these kids who especially have this open mouth breathing at night, there's a number of things that are happening. As the jaw opens up, again, the tongue, everything else goes to the back of the throat. Oftentimes that can cause apneas. But two, the growth hormone that is released, when their jaw is growing, it is growing downward and backward because that's the position of the jaw when the growth is happening. The growth of the lower jaw is up here at the condyle. So if that jaw is closed and forward, then that growth is directed forward because part of the growth is determined by the forces that are placed on the jaw. So if you, for instance, had your jaw like this every night, then your jaw would be more likely to grow forward. If you have it like this, it's more likely to grow down and back. And so one of the very simple things, and we can link to some articles about this, is something called buteyko mouth taping. And that is a technique to help kids keep their mouth closed at night when they grow. We can do another video on all the details about mouth breathing versus nasal breathing, but just know that if you are nasal breathing 100% of the time and your mouth is closed when you're growing, you're going to have less allergy problems, less sinus problems, less asthma problems, and you're going to have the most ideal growth that you can have based on your genetic potential. So in this case, we see a downward, backward growth pattern. This is something that we want to try and influence in a positive way. This is an image of the jaw joints. So this child, even when his teeth are together, he is posturing his jaw forward. This is what we call an airway protective mechanism, meaning that his airway is smaller. It's not easy for him to get air through his nose and mouth when his mouth is closed. So when his mouth is closed, he moves that jaw forward and the jaws come out. Now, that would be great if he did that during night when he's sleeping, but what happens is at night you get the opposite and the jaw drops back and then you have that poor growth, and then during the day they tend to compensate either with moving their jaw forward or with something they call forward head posture, which is literally if you see a child and their head posture is forward, like almost always it looks like they're slumped forward, that is an indicator. That's a sign that maybe there is some airway issues that need to be evaluated. So how do we evaluate these airway issues? So with the 3D imaging, it becomes much more simple. So this image shows us a number of things. So one, it shows us what's happening with the tonsils and adenoids. And two, it gives us the overall volume of the airway. Now I want to point out this is not a diagnostic tool. So when I look at this image, I can't say, oh, this child has an airway problem, he needs to get that fixed. It's a screening tool. So when I see this, I say, okay, well that airway constriction, and in his case at the level of the tonsils and at the adenoids, is smaller than normal. So that leads me to wonder and to ask more questions. is this child having some sleep concerns? Are there issues that need to be addressed? Do we need to find out? Do we need to order a sleep study for this child? What questions do we need to ask? This is what this image helps us to determine. So at a baseline, this minimum airway of constriction or minimum constricted airway should be about 10 times the patient's age. So if this child was, say, 9 years old, if they were 9, then their minimum airway constriction should be about 90, or 90 would be considered normal. And again, there's things that influence this, the position that you take the image in, whether they're upright or laying down, but that's a general rule of thumb. So when this shows up at 22, that's quote unquote normal for a 2-year-old. Obviously, this patient isn't 2 years old. So that's a red flag. That's something that we need to investigate. Additionally, when we look at the images, we can see the tonsils sticking out from the side in this image here. So we can see those on the right and on the left coming out into the airway space. And we can also see the adenoids, which is up here, invading that airway space. So when this child has his mouth closed, it is not easy to breathe. So hence you see this child breathing through their mouth often, which then the cycle continues. The more you breathe through your mouth, especially at night, the more you have the downward backward growth, the harder it is to breathe through your nose, and the cycle continues. So we need to disrupt the cycle, but this is what this child has to breathe through. And this is like about the same size as a McDonald's straw. Every time this child's mouth is closed, that's the amount of room that he has to breathe through. So we ask the question, so what is going on? This is an airway questionnaire. We have a link to this airway questionnaire on our website. I would encourage you, if you have suspicions or you suspect something might be going on with your child, hop on the website and fill it out and just see like how many of these signs or symptoms are there. If there are a lot of them, this is something that you want to evaluate because it may be a reason that your child is not thriving in the way that you feel like they should or can, or maybe the same as some of your other kids. And where we get involved orthodontically as it relates to airway is jaw size. So this image here shows us how wide the top jaw is compared with the bottom jaw. And so this top jaw is designed to be about 3 to 5 millimeters wider than the lower jaw. Why is that? The upper teeth are designed to fit on the outside of the lower teeth. And if the jaw size is correct, you'll see that this upper tooth fits about 3 to 5 millimeters wider on each side in order for the teeth to fit together and upright in the bone. So from a purely dental standpoint, we want to see the upper jaw 3 to 5 millimeters wider than the lower jaw. From an airway health standpoint, the wider the upper jaw is, everything that's attached to the upper jaw is going to become wider as well. So for instance, the soft palate, which then goes into the tonsillar pillars, that whole apparatus is going to be widened. And as that happens, those tonsils will come apart more. It's going to be easier. You'll see the airway open up, and now it's easier for that child to breathe through their nose as those constrictions are lessened. Additionally, when we look at the airway from the bottom jaw standpoint, when the upper jaw is the correct width, now those teeth on the bottom that were tipped in can now tip outward. And as those teeth tip outward, it allows more room for the tongue to be in the mouth versus having it pushed back by the lower teeth being tipped inward. So what are we going to do for this child? What can we do to make a positive difference in both the dental and the airway health situation? We're going to do something called expansion, specifically maxillary expansion. Expansion has been around for years and years and years, but the more imaging that we've had, especially in the last decade or so with 3D imaging and the more studies there have been on airways, the more benefit we've been able to realize and measure as it relates to airway health. And so this is what the expansion looks like. So you can see on the top, there's a little expander that's hooked to the teeth. That expander stays on full time. On the bottom, in his case, we're using some aligners, some clear aligners to move those lower teeth out and create room for the tooth on the bottom left that needs room to come in eventually. And when we're done, this is what the jaws and the teeth look like. But what's interesting is when I show you these pictures, and if I asked you, how far apart were these pictures taken? I've had a lot of people guess, a year and a half. These images were taken 4 months apart from one another. And what happens is when you have a child that has an airway issue and they're not breathing properly and they're not sleeping properly, when you're able to correct that issue and you're able to establish the correct size of the jaws, oftentimes we'll see what's called rebound growth, meaning that the body realizes, whoa, things are better now. And so it starts to release that growth hormone and we see these growth spurts happen. And it's a real transformation in the child's life. I mean, a lot of these kids are struggling. They're struggling in school. And it's not that they're bad kids, it's that they have airway issues. They can't concentrate because they're not getting restorative sleep. So basically, they're walking around tired all day long. In addition, their growth is being hindered. Again, 4 months apart, you can see the difference it makes in the growth and in the structures of the face when the jaw size is corrected. So from a dental standpoint, you can see the difference in the size and shape of the arch. You can see those lower teeth tipped outward, making room for the other teeth that need to come in. And probably most importantly, when we ask these same questions about a year later or so, you can see the difference that this has made in this child's life. If you suspect that your child has airway concerns or you want to get more information, this is a complimentary service that we offer. Have your child schedule an appointment. We'll take all the imaging. We'll look at things together. If an ENT referral is indicated, if they need to see a functional therapist, anything else that needs to be done, we'll send those referrals. Or if your child requires orthodontics to correct the problems, then we would be happy to do that at our office. If you guys have any questions or any other feedback, or you want us to do more videos like this, let us know, and we'd be happy to do that. Appreciate you guys and have a great day.